Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. Got a great episode for you today. We're going to be talking about the future of AI-driven imaging. And our guests are Razik Yousfi. He is Senior Vice President and General Manager for AI products and is leading the pathology and radiology businesses at Tempus AI. And also Chiranjiv Singh, he is Vice President and General Manager of the Pixel Division at Tempus AI. Gentlemen, thanks for being with us today.
Thank you for having us, Brian.
Thanks, Brian.
So let's start with introductions. Razik, can you go first and tell us about your role at Tempus AI?
Yeah, absolutely. So as I mentioned, I lead a business called AI Products. We basically focus on all of the innovative AI products, generally speaking, based on multimodal foundation models. We basically are leveraging those models to build innovative products that we ultimately distribute to our provider partners, and as well as work with life sciences on those ideas and initiatives. I've joined Tempus last August as way of acquisition of a company called Page AI. I was at Page for 6 years, leading technology as CTO for 5 years and leading the rest of the business as CEO up until its acquisition by Tempus. Page focuses on digital and computational pathology, and we've been, since the acquisition, integrated fully within Tempus to also enable us to coalesce the pathology and radiology businesses into a broader imaging division to build more multimodal products.
All right, excellent. Chiranjiv, how about you?
I've been at Tempus for about 3 years, leading the radiology AI team at Tempus. I'm part of the broader AI products team with Razik now. And the focus has been how do we take benefit from a lot of the radiology data that we have and contribute along with other multimodality information for AI products that we can build. Prior to Tempus, I've been at 2 other radiology AI startups and spent a long time at GE Healthcare.
All right, very good. Thanks for being with us, both of you. So let's get started. So we're talking about kind of broadly diagnostic medicine here, and pathology and radiology are sort of 2 branches of that, but they've always been kind of pretty separate. But they're starting to move closer together. Razik, can you give us a high-level overview of Tempus's strategy for AI and imaging, particularly how it applies to radiology and pathology?
Yeah, that's a very good question, Brian. We were fortunate to be able to cross multiple modalities by being at Tempus. We ultimately are an organization that focuses on diagnostic testing. So we have this ability to basically look at patients in a pretty deep way by ultimately being able to sequence them. Pathology and genomics are very close to one another. Typically, no one, for example, tells you have cancer until you ultimately have a pathologist look at a glass slide and identify the cells that are cancerous. And typically that's unfortunately only the beginning of the journey, because you need to be able to characterize that cancer and understand its precise genomic profile to be able to have better therapies for the patients and maximize outcomes and survival for those patients. So we've always looked at Tempus and Page as very synergistics from the ability of leveraging data and AI to build better innovative AI products. And so imaging within Tempus makes a lot of sense, because now we can basically look at pathology images and genomics data sets and really try and infer as much genomics or biomarkers or gene expression as possible from a pathology slide alone, which ultimately enables some of those cancers to be characterized earlier in that diagnostic journey for the patient. And we very similarly think a bit about the same way for radiology, because if we can more rapidly and earlier in the screening journey for the patients identify patients that are higher risk, that exhibit, for example, certain biomarkers, and by leveraging radiomics, we can more rapidly direct them to potentially the pathology lab and ultimately getting sequenced. So we're also very much believers that combining information from multiple modalities ultimately enable us to have a better, clearer picture of the patient. And we believe that while radiology is more pervasive, it doesn't necessarily have the resolution that's necessary to have the comprehensive view, but it can certainly enable us to go confirm some of those findings with more definitive testing and definitive modalities.
Yeah, for sure. So I think our audience is probably pretty familiar with the challenges that radiology faces, but can you, Razik, can you tell us about some of the key challenges that pathologists face, and how does that create bottlenecks in oncology care today?
Yeah, that's also a very good question. In many ways, the number of cancer cases is on the rise. We are more effective at detecting cancer pretty early. And as the number of cancer cases are increasing, ultimately the number of cases for pathologists are increasing. But quite interestingly, the number of pathologists per capita is pretty stable and doesn't necessarily increase over time. And what that basically means is that there is a higher number of cases per pathologist that they have to basically look at, and that becomes a real challenge and a bottleneck, because there's just not enough time in a day to be able to look at all of those cases. The second thing is that not all cancer cases get diagnosed the same way. Although you look at biopsies or resections through typically the microscope, there are subspecialties across pathology, and not every subspecialty is equally represented in the US or in the world. So again, as we really think about one of the challenges, the democratization of subspecialties is a complex one. And finally, the reporting requirements are also quite more extensive and also more complicated for pathologists, which ultimately you not only have this problem of number of cases go up, but you also have the complexity of reporting on each case go up. So ultimately, that becomes just very, very overwhelming. So when you think about all those things together, you really can imagine that AI and the utilization of AI could help ultimately pathology labs to some extent, can help pathology lab with those high volumes by being able to assist the pathologist in some of their tedious tasks. You could enable pathologists to have more consistent diagnosis by offering them tools that enable them to ultimately get better characterization of images and so on and so forth. And because of that, we believe that pathology needs to go digital, but pathology has been vastly unchanged for the last 150 years. People are still using the microscope as the gold standard to be able to look at glass slides today. And going digital is not an easy task. We all know that radiology took probably something like 20 years to go digital. We're seeing the same slow movement in pathology. And we've been very much advocating for the field of pathology to go digital, advocating for having mechanisms to find the budget for the capital expenses associated to buying scanners, and ultimately enabling people to look at images on a screen instead of leveraging a microscope to look at those images.
Yeah. So do you feel like pathology, I mean, it seems kind of obvious, but pathology is kind of catching up to where radiology has been for quite some time now. Would you say that's accurate?
I think it's there are a ton of analogies that you can draw between radiology and pathology, and I think the end state probably looks roughly the same, where every case, every study is being looked at digitally, and you can easily apply AI to those images. I think there are a couple of differences. Number one is when radiology went digital, AI wasn't as pervasive, so there wasn't really this synergy between going digital and leveraging AI. And I think for pathology today, you kind of see this pull to use AI that kind of also helps with the justification of going digital. To some extent, the business case is better. But I want to say that one of the key challenges in pathology is no matter what you do, your initial samples are physical. A biopsy is a physical block of tissue, something with a resection. So you go from and you're not skipping that step of creating a slide. So you will still get samples, you still need to get slides. And to some extent, going digital means adding a step where you have to digitize that slide. Radiology is slightly different, right? Because you get a physical signal that ultimately you can transform into an image, but remains by and large non-invasive. So you see a little bit of a difference there, which makes maybe the motion of going digital slightly more complicated in pathology. Lots of similarities, a few key differences.
Yeah, because radiology is acquiring digital signals like right at the source, right? Chiranjiv, do you kind of see parallels between the path that pathology is on right now and where radiology's been?
Yeah, I'd echo or agree with what Razik said. The path is in some ways similar. Like if I look at the radiology, it started with equipment which is acquiring the digital image, but then radiology departments had to acquire a PACS, and there was, RIS and all the supporting architecture which could enable the complete digital workflow. From that aspect, I see similar things happening in pathology. It's not just about a scanner, which is digitizing the glass slide, but then you need a IMS or a viewer or a LIS, all those accompanying IT infrastructure, which again further adds to the budget. So from that aspect, the journey is similar in some ways. I think the big difference is where you're starting from. You started with a DICOM image for radiology once all detectors and all modalities had gone digital. Here, you're still starting with the glass slide. But beyond that, it's a very similar process and journey.
Very good. So, Razik, Tempus has a portfolio of AI applications. These include like one of the first FDA approved application, like Page Prostate, and a lot of these are all designed for specific tasks. Can you walk our audience through the evolution from these tools to some of the large scale foundation models that Tempus is building?
Yeah, absolutely. And in many ways, the evolution of these tools is also following the advances that you currently see in the world of AI and the advent of large language models and ultimately large vision models. We originally, so Page was a spin-off from Memorial Sloan Kettering, and what they had done pre-inception of Page as a company is basically leveraged advanced AI, specifically deep learning and multiple instance learning, to be able to train pretty large scale models that were capable of detecting cancer on histopathology slides near perfectly and in prostate, breast, and basal cell carcinoma. So there was a Nature Medicine paper we published associated to that. And we felt like we had a really good, I guess, a recipe for being able to build those applications. You take a lot of domain-specific images here, images of prostate needle biopsies. You pair those large data sets with pathology reports. We had this innovative technique where we could just understand whether a report ultimately was calling a patient positive or negative, but we didn't have to point out where the cancer was on the slide, and it really enabled us to shift a bit away from traditional AI leveraging annotations to building fairly large models that have a very good accuracy. And if you think about our prostate application, I think it was built on something like 60,000 slides. And that's pretty large when you think about it from a dataset perspective. Each slide is between 1 and 2 gigs. So you're starting to reach pretty big problems of training and compute requirements. So we felt like we had a good plan. So we did that in prostate. We then shifted a bit into breast, and then we shifted into colon. And we kind of realized that we could be doing this forever. But number one, it takes a ton of time to curate that data and ultimately collate those data sets. Number two, it also takes a ton of compute when you have that amount of data to be able to train a system. And number three, we also realized that this recipe was only working for tasks and cancer cases for which you had a lot of data. But what about rare disease? What about rare biomarkers? You couldn't just really repeat this because there was just not enough data to be able to leverage the same techniques. So before I think things were called foundation models, we had this idea that based on the hypothesis that a lot of the cancer cases share the same morphology, that maybe we could train a very large system, leveraging all of the images that we have access to, regardless of the type of cancer that we were trying to detect. I think we originally called that universal embeddings or anything that ultimately morphed into the million slide model. But we engaged in that journey to basically build a very, very large model, a large vision model that was originally trained on 200,000 images to just serve as a baseline for building applications, but a bit in a task agnostic way. So let's build a model and then let's use that model as the springboard for applications. We can customize those applications with smaller data sets, but we don't have to reinvent the wheel. We had back then partnered with Microsoft Research, and we scaled the approach to using 1 million images. So that also led to a Nature Medicine paper that really enabled us to show that using that model, we could not only reach the same level of accuracy as our, I guess, task-specific models, but we were also able to start detecting cancer on a wide range of tissue types without necessarily having to pre-train for that particular task in mind. That was obviously a foundation model. We have since then continued that journey and built a much larger foundation model called ViroCop 2G that's built on roughly 3.5 million images. The network size is, I think, 1.8 billion parameters. So it's a pretty large model as models come, especially in the field of imaging and at the intersection of imaging and healthcare. And that model really enabled us to unlock not only our ability to build applications at a pace that was unmatched before, but also enable us to build applications and products in a very different way. So instead of going one tissue at a time, we were able, for example, to build an application called Pan Cancer Detect that can detect cancer on more than 40 different tissue types out of the box. And that application doesn't require any further training on each of these different tissue types. It just works out of the box on 40 plus tissue types. So that really enabled us to dramatically increase our ability to have those applications with multiple end goals at the same time. The second thing is we really had this idea that there was a lot more in pathology images than what a pathologist typically takes a look at. And we had this intuition that because of the size of the data, there was a lot of biomarker information that maybe a very large AI system could grasp on and ultimately predict. We started originally with small applications that were able to identify one particular gene and mutation, things like microsatellite instability in colorectal cancer or EGFR mutations in lung, to ultimately building a much larger system that's been trained with a very large number of images, but also a very large number of DNA gene reports from Tempus and also another large cancer institution here in the US. And that was probably the biggest high throughput digital biomarker panel that is capable of predicting more than 1,600 biomarkers and 505 genes from one image, from one AI system alone, and in less than 5 minutes. So those foundation models have really enabled us to really unlock a class of products and applications that was not possible before.
Well, this kind of reminds me of that saying of data is the new oil for AI. And when it comes to foundation models, it seems like it's really important to have like high quality data and to pair that data with, kind of outcomes and that kind of thing. Can you talk about this kind of data moat that Tempus has built, specifically regarding the millions of slides that are paired with clinical and molecular outcomes that kind of allow things like the Tempus Foundation model to see things that maybe a standard pathology and AI and radiology AI model might miss?
Yeah, and I think you're spot on, right? In the world of building AI systems, data is the fuel and is a critical element of being able to build those extremely large systems. What's very interesting is that Page had collected, prior to its acquisition, a very large data set of pathology images, more than 7 million images, with associated pathology reports and also associated reports of sequencing data, specifically DNA. At the same time, and at a much bigger scale, Tempus has generated an extremely large amount of sequencing data, both DNA and RNA, all longitudinally tracked and associated to all modalities of data for particular patients. So that means that for every glass slide that gets created, we generate an H&E image. For every patient that comes into the lab, we ultimately also or for every case that comes into the lab, we also get access to the history, and we were basically capable of coalescing those data sets to have a very unique and differentiated asset that connects the dots between those very complex modalities in a way that probably nobody else has been able to do before. So by having that data set, we're capable of embarking on that journey to build the largest foundation model in oncology that not only is built on top of the amazing models we've built at Page, but also built on top of the amazing data set that Tempus has generated over the years to ultimately have something that can uniquely associate imaging to genomics, to clinical notes, to survival treatment and outcome data. Without that data, and there wouldn't be an easy path to build something like a large oncology foundation model.
If I look at a lot of foundation model work being announced today, and if it's only from a developer that has radiology data, yes, you can accumulate millions of scans, but your ground truth is based on what the radiologist read or annotated on those scans. Right? What we are setting up and would be an enabler is not only can I in the future be extremely confident that, hey, what I see is cancer because I have the biopsy results, but because it's not just biopsy results, if I have genomic results for those patients, I can start on having large volumes of these data, build foundation models that can then go into predictions. Hey, I'm seeing a nodule. I can confirm that that nodule is cancer. And with a high degree of, accuracy, I can predict that I can see these mutations, biomarker mutations in this patient. So the kind of depth from that multimodal data will enable us to do things which individual modality foundation models will struggle to do just because they don't have that depth.
And how do you think that this level of large scale AI is going to change the day-to-day work for a pathologist or an oncologist who's making treatment decisions?
It's a very good question, and to some extent, we haven't really probably realized the full impact of this technology at the scale we believe it can eventually get adopted. The easy way to probably portray this is we're generating more insights. So ultimately, we're giving more information to a pathologist and to an oncologist, and they're in the decision, they make the final decision. The same way they can order an additional test, we give them additional AI-derived tests, and they ultimately can leverage that information to make better informed decision for the patients that's in front of them. Sometimes it enables them to not miss something. Sometimes it enables them to maybe identify a different pathway for the patient, and sometimes it enables them to go confirm maybe something that they were suspecting was a different type of tests or a different modality. But we believe that ultimately our objective here is to surface as much information relevant to the patient as early as possible in the journey for that patient to the right physician for them to be able to act upon it.
Now, let's hone in on a specific application that Tempus has, Page Predict. And this is a lab developed test in LDT. How does this move pathology from just, identifying cancer on a slide to predicting information like biomarkers right from an H&E image to help speed up turnaround time and maybe, prioritize downstream tests?
Yeah, we've deployed Page Predict in the Tempus lab very specifically for Q&S cases. In other words, for cases that were sent to us for sequencing, but for which we don't believe there is necessarily enough tissue to be able to sequence them. Today, when there is not enough tissue for sequencing, the ordering physician just gets not a lot of information back because we have not sequenced that case. So what we're doing now is we basically, because we have access to the image, we're running Page Predict. Page Predict, again, was designed as a mechanism to generate biomarker status and information from that image with a certain level of accuracy that varies from one biomarker to the next. Some of them do better at negative predictive values, some others at positive predictive value. But we're ultimately generating a report that we send back to the ordering physician. So instead of telling them, we couldn't sequence that case, we maybe need more tissue, or you need to go in a different route, we're providing them with information. And it goes back to what I was saying maybe a little bit earlier. With that information, they have more options in front of them. They can potentially, again, maybe send us back more tissue and we can sequence the whole case. But they can also use maybe a different modality, such as an IHC or a PCR or a smaller panel to go confirm something much more rapidly that may ultimately enable them to put potentially a patient on a certain drug regimen much faster than they would have otherwise. And we know for certain aggressive cancers, time is critical. So we look at Page Predict as a mechanism to plug a gap here, a gap when information is not made available, and that enables ultimately to improve turnaround times on information that can be very essential to that particular physician. That wouldn't have been possible without digitizing those images, and certainly not possible without building those extremely large systems that enable us to build all these amazing products.
Yeah. Let's turn to radiology. Chiranjiv, what are some of the key challenges that radiologists face today in the context of oncology care?
I think a lot of the challenges are perhaps similar to non-oncology care. They maybe get accentuated or highlighted even more when it comes to oncology care. I'll think of a few. So for example, it's very important to have access to prior images. You never want to make a diagnosis on the basis of just a single mammogram or a single CT. You want to compare it with the prior, and making sure you have timely access to that prior is extremely valuable. You put a patient on therapy, most cases are getting multiple imaging modalities done. Again, having access to all the modalities in a combined viewer, making sure you're looking at not just one point in time or one scan is a big challenge. The second thing I hear often is, radiologists are tasked with the job of doing a differential diagnosis. And because our data systems are so broken, they often are forced or are made to operate and do that differential diagnosis without having pure clinical context. A classic case I hear is, hey, I'm being asked to review response of therapy for a patient, but if I don't know that this patient has been put on immunotherapy, I may misdiagnose what is pseudo-progression as, hey, this patient is worsening. So all that information is available. It's available somewhere else within the EMR in a different context. And I've heard so many radiologists saying that they have to spend hours, if not days, getting that right context on time so that they can do that correct differential diagnosis. The last one that I hear very often, and it's not, I think, related to the work that the radiologist is doing, but it leads to what happens after that, is connecting that output to the physician treating that patient. Often, yes, you've read a CT, you identified a nodule, but how do you make sure that patient gets followed up on time? You've read a prostate MR, given it a PIRAD score, how do you make sure that goes to the interventional person, the urologist, or whoever is doing the biopsy, all that segmentation follows through so that they can take that next step in that patient journey. So that care coordination and that follow-up becomes a very important part. And again, going back to what I said a minute ago, because our systems are so broken, the data will sit in a PACS, but we've not figured out the right way to make it move. We've not figured out for the right clinical context to come in. The entire outcome gets broken.
Hmm. How do you think that connecting the imaging modalities with like a unified data strategy would reduce issues like screen fatigue or the need to do repeat procedures?
Yep. So I wouldn't say I'm not sure how it would impact things like screen fatigue, but definitely the moment you start bringing in all these modalities together, to the point that Razik made earlier, you are now have the ability to give better insights to the clinician. So if you are on the CT image telling the radiologist that, hey, I'm confident this is cancer, the next step may not be a follow-up CT a year later, maybe an immediate interventional procedure. So it's reducing that time from diagnosis to start of treatment, which is very essential in oncology.
Hmm.
So things like that, where you can bring in those insights from radiology, pathology, and eventually use that data to improve your models, is eventually adding to how fast and how accurate the treatment journey the patient goes into.
Mm. Do you feel like Tempus looks at radiology, at AI and radiology maybe a little differently than other companies?
I think yes. And I think maybe I'll borrow something I heard Dr. Nina Kotler present maybe a month ago, where she spoke about two axes of radiology AI. There is that axis in terms of models, what capabilities those models have. And there is a second axis of infrastructure, or what workflows are enabled through those models. And I think the way we've looked at radiology AI at Tempus, we've always looked at what can we do better in terms of the insights that we can give to our radiologists. I'll give you examples. We now have a lung product, which is the first FDA cleared product, which not just identifies nodules, also characterizes them and gives a malignancy score. We've done the same in prostate MR through a partner product. So the goal being, can you take these models beyond just detection and triage and start giving insights which have more value to the workflow? On the second layer is, once you've identified that, how do you integrate that with the rest of the health system? Who are the physicians downstream, be it a pathologist, be it a urologist, a pulmonologist, whoever is the clinician who needs to act next on the patient? How can you make sure that information passes on from the radiology system to the other systems so that appropriate and timely action can be done? And we've done a lot of work in lung cancer, starting in other oncology areas, where we're building those bridges or pathways for that information to flow from the radiology systems like PACS to other systems in the clinical setting.
Very good. Yeah, it looks like we're drawing to a close. Would like to send our viewers on with maybe some advice on how they can build a unified AI strategy that incorporates solutions for both radiology and pathology without getting overwhelmed with all of the AI options. Chiranjiv, what kind of advice would you have for people who are watching out there?
I would say what I've seen is it's always about bringing the right people together in the health system. And when I say the right people, it has to go outside of just radiology and pathology. You need to bring in the oncologists, you need to bring in the leadership, because a lot of these challenges are beyond just a single modality or an AI challenge. It's about enabling that entire workflow within the health system. So I think my number one advice would be to set up the right team, including clinical leaders from oncology, including IT, and then tackling it as what can we do to deliver better care for the patient, rather than what can we do to improve efficiency for one set of users, be it radiology or pathology.
Great advice. Razik, how about you? What kind of advice would you have for our viewers?
Yeah, I think, the number of AI solutions available out there for building applications may be a little bit overwhelming. And in so many ways, I think people are sometimes embarking on that journey to go build their own entire stack, spending a large amount of people and a large amount of money trying to reinvent the wheel. So we strongly believe that ultimately there is a very large opportunity for everyone to build better products that have a very high clinical impact. And I think people should focus on those higher value products with a higher, clinical impact, and to some extent leverage existing tools and technologies available out there. We have embarked on that journey to build foundation models because to some extent, we needed to, and to a better reason, we have a lot of data. And we're very happy to partner with other companies to give them access to those technologies for them to build those more advanced, high utility, high clinical impact products. So I think to Chiranjiv's point, let's not reinvent the wheel. Let's focus ultimately on what we're trying to do for the patients, and let's find partnerships that make sense, because ultimately what we want is just better, safer ways of providing and enabling precision medicine.
Yep, and that's what it's all about. All right, well, I'd like to thank Razik, Yousfi, and Chiranjiv Singh of Tempus AI for being with us today, gentlemen. It was a great discussion. I appreciate your time.
Thank you, Brian.
Brian, it was a pleasure.
All right, signing off for the Imaging Wire. My name is Brian Casey.